just about every neurosurgery center there is around the world. Truly a global citizen. But where I really came to appreciate his impact, which has been huge, is when he took over as editor of the Red Journal, and I date myself by calling it the Red Journal. I don't know if people still do that, but he transformed that at a very difficult time in publishing when the world was changing rapidly, and he managed to be ahead of it and lead it, and really turned it into a force for global education in a way that it wasn't before, as he took advantage of the new technologies, and all of our lives as neurosurgeons are richer because of his impact. And so it is an enormous pleasure and honor to have him with us here today. And Nelson, thank you for being here, and you can go ahead and start sharing your screen.
Thank you very, very much for the invitation, Cameron, and the rest of your faculty at the foundation. And I'm pleased to share part of this morning with you. Can you see my screen yet?
Not yet.
Not yet. Let's see.
There we go.
About this. So my brief this morning is really to talk about a very near and dear subject to me, Cushing's disease, one of the functional pituitary adenomas, and go through some of the current management and both surgical, radiosurgical, and some of the emerging medical therapies as well that have come on board over the last few years, in the last 2, 3, maybe 4 years. So that's my brief this morning. I'm not going to go into a description of the diagnosis and the presentation of Cushing's. That's very well known to the audience. I'm going to concentrate on therapy and management and how we treat these patients as opposed to making the diagnosis. So all the assumptions from this point forward is that we have a patient who has a diagnosis of Cushing's disease that's verified biochemically and by MRI criteria. So the strategy for managing these patients is really as follows. So strategy obviously is the maneuvers that we bring to play to achieve a specific goal. One is we want to have temporary or permanent cessation of hormone hypersecretion. 2 is cytoreduction of tumors, and 3, elimination of mass effect, which is usually not as big a deal with patients with Cushing's because most of these tumors are microadenomas. And of course, do no harm, complication avoidance, and preservation of function. This is the territory in which we'll be dealing with. This is the pituitary gland. This is a coronal cadaveric dissection from rodent carotid artery, the pituitary stalk, where tumors can also reside. The majority of the tumors are in the pituitary gland, either in the midline, the mucoid wedge, or placed laterally or extending even beyond the gland into the medial wall of the cavernous sinus or frank cavernous sinus invasion. So this is the area where we were. Things to consider. Notice that I've just put a few things here in mind. There's usually a low rate of invasion in Cushing's. Our goal is 100% resection to induce primary remission and sustained clinical remission. One of the biggest issues with Cushing's is 2 things. Number 1 is the unrecognized dural invasion in many cases into the medial wall. And then secondly, the difficulty in localizing tumors. There's about 20 to 30% of these tumors that are frankly not visible on MRI scans. The goal is the complete en-bloc resection of the tumors, and if there's invasion into the cavernous sinus, to remove tumors that are accessible and sometimes may require medial wall resection. One of the more confounding issues is tumor consistency. Sometimes you get into fibrous, tenacious tumors, maybe sometimes with previous surgery, scar tissue, and poor tissue planes. Obviously, the adjuncts for diagnosing imaging is critical, MRI imaging, to identify the lesion and the extension of the lesion. And then surgical technique must be applied to the specific disease. When to operate? You operate when you've got a clear diagnosis and imaging data as well. Key surgical maneuvers, we'll go over that with some videos. Intraoperatively, touch preps. I use touch preps. They're very effective in identifying tumors with very small samples, all frozen section. And of course, permanent section with immunohistochemistry to confirm ACTH positivity. And then early assessment of results. Excuse me. And as I said, relief of mass effect is usually not an issue with Cushing's in the majority of cases. The key surgical maneuvers: a wide opening of the sella, removal of bone from cavernous sinus to cavernous sinus and clivus to anterior, so that you can get good access to the whole entire gland. And you want a careful, systematic, and complete exploration of the gland, even where you know where the lesion is. Selective adenomectomy is the goal. And as I said before, the way you tell whether you have accomplished the goal is the early postoperative assessment. Every now and then, you may have to extend the resection to a hemihypophysectomy or a 2/3 hypophysectomy in those cases where there's no clear delineation of a lesion. And we'll talk about medial wall exploration in a minute. This is from Jules Hardy's paper in the mid-60s, where he talks about, he coined the term selective adenomectomy. In other words, the surgical strategy that removes, this is an adenoma, for example, on an H&E, this is the reticulin border, and this is the normal gland. And so selective adenomectomy, the concept is to remove the adenoma, excise the adenoma, and only the adenoma, leaving the normal gland. And that was coined by Jules Hardy. But actually, if you think about it, the presence of the histological pseudocapsule with that reticulin compression around the adenoma was actually initially discussed as way back in the early 1900s. Why do you use the pseudocapsule? Well, the advantage is that it follows the natural planes layer by layer and improves gross total resection for not just Cushing's, but for the majority of functional tumors. And you eliminate the guesswork as to when you've got a total resection, and there's better chance of preservation of the normal gland. It's very important to protect that pseudocapsule, even where it ruptures during dissection, and because it's your guide, it's your roadmap to getting a gross total resection. Here's a video from many years ago. This is over, gosh, must be 25 years ago, this video or something. But I kept it because it's from the days where we do this microsurgically with a microscope. This is an adenoma being removed. And you can see that there's a speculum in place as we used to do it in those days. And you can see that the actual excision of the lesion using that tissue plane, the tumor capsule, is what this illustrates. And this is the MRI of the patient. And this is what that looks like when you do it in that way. Here's on H&E, the nodule, and this is the ACTH positivity on immunohistochemistry, and this is reticulin stain around the margin of the tumor capsule, showing the integrity of that reticulin stain. Here's another case. This is a patient with a pituitary microadenoma. You can see that hypointensity surrounded by the enhancement of the gland. I'll show you, this is another case from my time back at Emory. I kept this one because it shows a fibrous adenoma being removed. This is the dissection of the interdural dissection. And you can see that this is the gland more red, and then the tumor is slightly paler than the gland surrounding it. But there's a clear demarcation between the tumor here and the gland here, and you can dissect around this margin, preserving that tissue plane and excising the tumor in that fashion. Here's another case. This is a pituitary microadenoma. This is a patient who's a 62-year-old male, and you can see the lesion right here. In this particular case, the nodule is sitting at about 11 o'clock. I'll show you that tumor right here. And you can see it's a very small, tiny nodule. There's a compressed anterior gland over that nodule, and we're using a real fine circular blade to circumnavigate that tumor pseudocapsule. And you can see it's beginning to show up as a tiny pea-sized lesion sitting in the top right-hand corner as we're looking at the surgical video. So there it is, and that's the same concept. And then we're going to finalize that excision of that little tiny pea microadenoma. Sometimes the tumors are consistency-wise are soft. Here's a tumor that's really very, very soupy, as it were. It's sitting in the far lateral component, and there it is, and we removed it from that far lateral component using that same technique. A very important concept is the inferior petrosal sinus sampling. This is used in patients who have negative MRI scans, which is about 20 to 30% of patients. And in this particular IPSS, you can see that the peripheral, central to peripheral gradient, and this is from the right inferior petrosal sinus, and this is the periphery and the left inferior petrosal sinus. So there's more than a 3-to-1 gradient following stimulation with CRH. And so this is a very useful tool. I alluded to the fact that in some cases, exploration may require deep cuts into the gland, as you see from this cartoon from Ed Oldfield's work about 20 years ago, where he describes the systematic exploration using vertical cuts separated by from each other for about 1.5 millimeters through the gland to search for deep-seated adenomas. And in some cases, even after full and extensive exploration, you cannot see or cannot find an adenoma. And in this case, you do this 2/3 near total hypophysectomy, retaining the stalk and a stub or nubbin of anterior pituitary gland. And their patients can achieve a remission with this. This is another cartoon from Ed's work. And in this case, we're illustrating the fact that you can get adenomas, ectopic adenomas outside the gland and in the infundibulum. I've seen 3 cases like this in my career to date. And the stalk looks chunky and on MRI scan, and there's no lesion in the gland, and you find a lesion supraglandular in the infundibulum. And this is a classic case that is seen very rarely, but has been reported. I did say we'll talk about the medial wall resection. This has been around for almost 20 years. This is from Ed's cartoon, and the medial wall is that portion of the dura that splits at the lateral edge of the gland, and the ventral split goes to form the anterior wall of the cavernous sinus. The deeper split surrounds the pituitary gland, and what it is that tumors can extend beyond the pituitary gland capsule, break through the medial wall. Here's the cavernous sinus carotid. And so in order to excise this, you have to make openings in the anterior wall as well as in the anterior wall, so that you can get at the tumor that has gone through that and excise the medial wall with it. And so what you do is resect the portion in the gland and then the medial wall, and then follow the portion that extends into the cavernous sinus to get a gross total resection. Not doing so will preclude that patient getting into remission. So this is from Bill Caldwell's paper showing access to the anterior wall of the cavernous sinus carotid artery for a tumor that has extended into the cavernous sinus. Engelbert Knops described the cavernous sinus classification of invasion of pituitary adenomas and later modified it. So 3A lesions are tumors that extend beyond the pituitary gland capsule, beyond the intercarotid line in the superior compartment above the cavernous carotid. That's a 3A, and then there's a 3B, which tends to be more invasive, and that's below the carotid and past the intercarotid line. Those tumors obviously pose a more significant challenge. How do we establish criteria? What are the criteria for remission? What we use is an AM fasting cortisol on the post-op day 2 and beyond, when we start measuring serially the post-operative plasma cortisol AM fasting, and we look for levels that are less than 2 micrograms per DL. That's the sweet spot. However, between 2 and 5 is also associated with remission, long-term and long-term remission. And then you can supplement that initial screening with later on measuring 24-hour UFC, CRH stim test, and DSTs and so forth. The timing is very important. Early post-operative testing is very important so that you can tell soon enough, within days, literally, whether the patient's in remission. And then later on, more sophisticated testing at 3 months and beyond. There are things that predict sustained remission for the long term are low is better. Lower AM fasting cortisols are better. So less than 1.8, for example, in this study is associated with sustained remission, was associated with remission, sustained remission in almost 100% of patients. What happens when there is persistent or recurrent disease, which is not out of the realm of possibility? First of all, the early post-operative assessment. The most important cause of persistent or recurrent disease, obviously, is incomplete resection or undetectable tumor after exploration of the gland and the cellar region. Or dural or lateral extracellular extension that is not addressed or dealt with at the time of surgery. Every now and then you'll find a patient who you thought you had the right diagnosis of Cushing's, but in fact the diagnosis was not cast iron, and that can be associated with, obviously, without improvement. And then secondary exploration for surgery within a short period of time if needed. Classically, those are patients who have some improvement and had positive histopathology, but do not remain in the range of hormonal remission. And those patients would deserve early secondary re-exploration. So I'm going to look at and talk a little bit about some other non-surgical treatments for Cushing's. This is a map of the various treatment options. So if you go from central to periphery, surgery obviously is done, attacks the problem at the root cause. But there are other things that can attack the problem at the root cause, including stereotactic radiosurgery and medical treatment with cabergoline or pasireotide. More distally, you can address the treatment at the level of the adrenals, which are obviously the particular gland that actually makes the cortisol. And there's several treatment options there that we'll talk about. You can see in the list. And then finally, treatment can be at the level of the receptor or the target tissues itself. So we talked about repeat surgery. The pros of repeat surgery is that it's the one option that can provide immediate cure and the chance for permanent remission. And it's more likely to be successful if there's a visible target on MRI that's accessible. Obviously, remission rates are slightly lower than primary surgery. So primary surgery remission rate should be in the high 80s, even 90%, if you have a clear defined tumor target on MRI scan. Whereas secondary remission rates are in the 60% range or thereabouts. Complications and tend to be slightly higher in repeat surgery, and recurrence rates tends to be slightly higher. So here's a data set from the literature. You can see a wide range remission rates for repeat surgery, but some, in general, right about the 60% range in general. Stereotactic radiosurgery, very effective for Cushing's, well, and reasonably well tolerated because the targets are small, and it's pretty effective also for tumor control. Obviously, biochemical control lags as compared with, say, surgery, which is more immediate. And in the meantime, most patients will require medical control for excess cortisol treatment. But it is of all the functional tumors, it is the one that's most effectively treated by radiosurgery. So here's a data set from across the literature. You can see the rate of biochemical control can be as low as 30% or as high as 85%. Tumor control is usually very effective with radiosurgery. Bilateral adrenalectomy obviously is a terminal event. It's you get immediate remission and usually permanent cure because you've taken away the source of the production of the cortisol. With laparoscopic techniques, it's reasonably well tolerated. There's always the risk of Nelson's from corticotrope tumor progression, and usually patients who have a residual adenoma and have to undergo adrenalectomy are best treated with stereotactic radiosurgery in the residual before embarking on a bilateral adrenalectomy. Surveillance with ACTH levels post adrenalectomy are very important because it's an early warning sign of the development of Nelson's, where you have rapidly rising ACTH levels following adrenalectomy. Some of the potential treatment options on the medical side, on the pituitary-directed drugs are cabergoline and pasireotide. Cabergoline targets the D2 receptors because the corticotropes, the cells that actually produce ACTH, have dopamine receptors on them. Pasireotide is also effective because it's a somatostatin analog, and again, receptors on the corticotropes allow for pasireotide. Steroidogenesis inhibitors, metirapone, ketoconazole, mitotane, and etomidate. Some of these drugs have been around for a while and continue to be used for treatment of Cushing's. The decision about medical therapy can be complicated, and you have to do this in conjunction with your multidisciplinary treatment team. And treatment obviously needs to be modified and individualized, and this is not one kind of judgment that is made by just the neurosurgeon. This is very important. It has to be embarked upon by the treatment team, the multidisciplinary team. So that's the message I would impart on this in terms of medical treatment. Cabergoline, as I mentioned, is useful for treatment of some cases of Cushing's because the D2 receptor is expressed on corticotrope. It's easy to administer, it's safe, and can be used for long periods of time, and can even is also even associated with tumor shrinkage. It does require higher doses compared with the doses we use to treat prolactinomas, sometimes up to 6 or 7 milligrams is used per week. So, and in those cases, patients need to be observed for the risk of valvular fibrosis or pulmonary fibrosis. So this is the response rate for patients undergoing treatment with cabergoline. And you can see that the percentage goes from anywhere from a third to as much as 2/3 of patients that will achieve good response with normalization of UFCs and so forth. Another drug very important that works centrally is a drug called pasireotide. Is a somatostatin analog, high affinity for SST1 and T5. and can be given either short-term or long-term treatment, a depot shot. Good data available, FDA approved, and provides the additional benefit of tumor shrinkage and low risk for complications or side effects. Here's the kinds of treatment response you can get with pasireotide, with UFC levels pre and post initiation of therapy. As I said, it also is associated with tumor shrinkage, with significant reductions of tumor volume as well. So an added bonus, although in fact, the tumors, Cushing's tumors are not very big anyway, but nonetheless. Adrenal therapies, the old standbys, ketoconazole and metilprom, mitotane, and etomidate, and then the newer ones are cilidostat, ketoconazole as well. The message with using steroidogenesis inhibitors: begin low, increase gradually, and it needs to be fine-tuned, and it takes a while to get to, the best steady state in terms of patient response. Patient needs to be cautioned and monitored very closely for the development of adrenal insufficiency. So that's really key. So ketoconazole, this is it's been around for a while. This is the dose, rapid onset effect, and it's efficacious in terms of remission rates, and you can see the response rates. Metilprom, also been around for a while, safe oral medication, rapid effect. It's effective in about 75% of patients, and reasonably safe with some tolerable but potential side effects. This is a newer drug. It's got a longer half-life compared to metilprom, so less frequent dosing. Effective in up to 86% of patients with normalization of UFCs, and then improvement in symptoms and so forth. Mifepristone, receptor antagonist, has been around for a while. As you know, it's used for other things as well as Cushing's. Reasonably rapid effect and effectiveness. Another receptor antagonist is also in this particular slide, and then levoketoconazole is a close relation of ketoconazole with higher potency than its cousin. Longer half-life and rapid action as well, and good symptom relief. I'm going to skip that and those two. Message here is, in terms of medical therapy, there's been significant improvement in the last few years. Cushing's still remains a challenging and evolving field. The best treatment, again, remains surgical resection as the first line of treatment. This, in my opinion, it remains a biochemical and not an anatomical disease. The principles of exploration of the gland carefully and completely to remove tumor, and to assess the results early and honestly with biochemical laboratory data, and long-term follow-up and long-term monitoring of patients is key to ensuring durable success and happy patients. So that concludes my remarks, and appreciate your time and attention.
Wonderful. Thank you so much, Nelson. Very lucid review, and someone who isn't involved with Cushing's disease, I really appreciated that and enjoyed it. My exposure to Cushing's disease was with Dr. Wilson in San Francisco, and it was always you had a good day when the morning after he'd done his Cushing's resections, the cortisols came back low, and he was happy, and the whole department was happy. It was, but I was curious about the inferior petrosal sinus sampling. I really thought that had sort of gone by the wayside. Is that something you're still using?
Yeah,
And talk to me
yeah,
about that a little bit.
yes, yes, and of course, the role of that study has remained as a physiological way of localizing where the tumor is when MRIs are negative, which is about 20 to 30% of cases with negative MRI scans. You get a negative MRI scan, the biochemistry is reasonably consistent, the clinical symptoms are reasonably consistent, and the IPSS is sort of the final nail in the coffin, as it were, to establish that this is coming centrally and not peripherally. And what it's not very good for is lateralization in terms of left side, left, right side of the gland or something. But it does, it in those cases where 2 out of 3 screening tests are positive and the MRI is equivocal, it's a very, very nice way of confirming that that it is in fact central. When you get a central to peripheral gradient of 3 to 1 or greater, there are not a lot of other things that it could be.
I see. I'd often thought it was something that I used to be involved with quite a bit, and the central peripheral piece I was always confident about, as you say, the lateralization. And one of the things that struck me about it, and I always thought was a little bit of a shame, was that it had never really become a particularly standardized procedure. When you started to really talk to people about how they did it, what their techniques were, whether they actually went into the IPS or whether they had a catheter kind of sitting at the junction of the IPS with the jugular, and the variations in the anatomy of the cavernous sinus, I thought was a big confounder that was never really well accounted for.
Yeah, I've been very fortunate working with pretty skilled interventional, and they park the catheter up there, and we've got the prolactin levels as an extra guide to normalize things. We do it with stimulation and trying to make sure that we label things right and we don't get confusion about the time of draw and the time, which one was above and which one was below. And you are right that the anatomical variation can sometimes be a confounder, and that's why we don't use it so much for the right to left as much as the central to peripheral.
Yeah. I was wondering too a little bit about some of the medical therapies in the patients who have not, enjoyed a surgical cure. Are you ever combining the central therapies and the peripheral? Is that something that's done?
Yeah. There are cases where a good example would be somebody who's got good response to carbergoline centrally, but at the same time they need something else to really cut into the excess production peripherally.
The adrenal, yeah.
Yeah, exactly. So maybe because they're very sick with the cortisol levels, even very high, carbergoline is not going to drop your cortisol levels as effectively as that. So you might want to, you could use a carbergoline, for example, centrally, and you could use a glucocorticoid receptor blocker peripherally. So, you have the best of both worlds.
Great. I want to open up a little bit. Rod or Zane, any comments or questions?
Hey, Nelson, excellent talk. And obviously Cushing's it's still a huge problem. When I remember I did my residency in Virginia, and both Ed Laws and Ed Oldfield, we'd have our Sunday clinic where you get these redo Cushing's disease. what's your sense on, in terms of gamma knife versus surgery? Do you still have I mean, obviously you're busy doing a lot of Cushing surgery. Do you feel like gamma knife or cyberknife has made an impact on that population that has recurrent disease, or is that still really surgical for you guys?
No, I think as I said, it's of the functional tumors, it's the one that is the most responsive to radiosurgery, better than acromegalics, it's certainly long shot better than prolactinomas, which typically don't do very well following radiosurgery. But Cushing's does, and the latency is not as long as 5-6 years with say acromegaly. I've seen cases with Cushing's a year and a half, 18 months, 24 months. And because it's such a small target in the majority of those cases, you can maximize, the biological therapeutic index in your favor and apply the best possible treatment dose and plan for it. So I do think for Cushing's, radiosurgery is a very effective tool. And for the recurrence, residual disease, after a good attempted exploration, and maximally safe exploration, and and you have persistent disease in the cavernous sinus, 3B or a 4, something like this, that you've done the best you could safely, and then this is the way to go, and temporize with medical management, but for the long haul, use the radiosurgery.
And then how about surgically? I know you discussed the surgical approaches. I remember both Dr. Laws and Oldfield were staunch advocates for micros, and they would do this intercapsular dissection. What's your approach on that? Do you use endoscopes or?
Yeah. Oh yeah, we've been using endoscopes for over 20 years. So yes, the short answer is yes. And that principle of an en bloc resection that's guided by the tumor pseudocapsule as being your margin of resection and gland preservation, and I think takes away the guesswork as to where is it and how did it, how much of it, and so on. And you can tell when you've got a lesion that's gone beyond the tumor pseudocapsule and breach the medial wall, or breach the cavernous sinus, or breach the confines of the gland. So I think it's a very good principle for which to work with. There are some cases, as I said, where the tumor its consistency is very mushy, and you don't have that reticulin membrane as an effective guide. That happens. Or there's a tumor that's got partial cystic degeneration, and so you have that sort of thing. Or I've seen actually cases where you have a Rathke's coexisting with an adenoma, so that makes it a little bit more challenging in terms of that kind of a dissection. But as a general rule of thumb, I would say that preservation and surgical resection based on the tumor pseudocapsule is a very important principle.
And do you use navigation? Because I remember, God, we would just take off the entire cavernous sinus to cavernous sinus, and then we would go superior and inferior. I mean, it would just be this massive view that you'd have. And we use the Doppler, but we did really use navigation. Are you using navigation to do these cases?
Not much. My colleagues in ENT use it as a very important part of their approach and so forth. But for the actual tumor exploration itself, it's not as the Doppler is a very valuable tool in localizing and following the carotid artery or any vessels for that matter. So that's a lot more reliable than doing that based on navigation. I mean, the Doppler is like real physiological way of identifying the flow.
All right.
Great. Thanks,
Nelson,
Nelson.
I know you're need to be in the operating room. I don't want to keep you past time and get you into trouble there. It was wonderful to see you this morning, and I really appreciate you being with us and sharing that talk with us. It was terrific. Again, great seeing you, and thanks so much for being here.
Thanks, Cameron. Thanks.